Uh, Heart failure is a very important subject. It is a global term for the physiological state in which cardiac output is insufficient for the body needs. Heart failure is a condition in which a problem with the structure or function of the heart impairs its ability to supply sufficient blood flow to meet the body needs. Heart failure is caused by any condition which reduces efficiency of the myocardium, either reduced contractility or reduced stroke volume or increased heart rate that impairs the stroke volume time, the heart hypertrophy of the myocardium or dilatation. There are several compensatory mechanisms are activated in response to heart failure: increased activation of sympathoadrenal system, activation of RAS, renin and angiotensin system, activation of endothelin system. All this will lead to angiotensin that will increase peripheral resistance. Increased resistance will impair the cardiac output and will overload the heart. So these are the compensatory mechanisms. It can overshoot. So we give angiotensin blockers. The angiotensin at the beginning is beneficial, but if it increases, it becomes deleterious. Categories of heart failure: we are dividing heart failure into right and left failure, forward and backward failure, systolic and diastolic failure, high output and low output failure. There are many different ways to categorize heart failure. Which side of the heart, left or right, whether abnormality is due to contraction, systolic, or relaxation, diastolic, degree of functional impairment conferred by the abnormality, NIHA class. We divide heart failure in NIHA class 1, 2, 3, 4. Class 4, dyspnea on minimal effort. Some doctors say dyspnea at rest. It is at rest or minimal effort. However, the problem is primarily increased venous back pressure behind the heart is backward failure, or forward failure if there is hypotension and shock. So backward or forward failure. Whether the abnormality is due to low cardiac output or high output as in cases of arteriovenous shunt or over fluid intake. Types of heart failure, again, systolic heart failure with reduced ejection fraction if it is below 40%. Diastolic heart failure if it is below 50, between 40 and 50. Again, the normal ejection fraction is 55%. We will say it 50. So if it is heart failure manifestations of dyspnea, but the ejection fraction is above 40, we call it heart failure with preserved ejection fraction. Below 40, heart failure with reduced ejection fraction. Symptoms and signs. Symptoms: orthopnea, paroxysmal nocturnal dyspnea, or pulmonary crepitations, peripheral edema. Symptoms as jugular venous congestion, edema of lower limbs, enlarged tender liver, hepatojugular reflux, ascites. Symptoms as cold periphery, oliguria, mental confusion, dizziness, narrow pulse pressure. Laboratory measures that can suggest heart failure: hypoperfusion, hypotension below 90, bradycardia below 40. Bradycardia is below 60, but if it is below 40, it's severe bradycardia. Tachycardia below 100, more than 100, but if more than 120, severe tachycardia. Abnormal respiratory effort: the normal respiratory rate is 16, maximum 20. If it is above 25, it is abnormal. We divide functional class heart failure into one: no limitation of physical activity, but the patient is having coronary disease, hypertension, tiredness, palpitations, shortness of breath. Grade 2, slight limitation of physical activity. Heart failure is dyspnea on doing usual daily efforts, but class 1, more than the usual daily efforts. Class 2, the usual daily efforts. Class 3, dyspnea on doing less than the usual daily efforts, marked or noticeable limitation of physical activity. And the class 4, as we said, on minimal effort. This is the classification of heart failure. Reduced ejection fraction below 40. Heart failure with ejection fraction above 50 is called preserved ejection fraction, and we will discuss the causes and the manifestations. Between 40 and 50 is middle or mid-range heart failure, diastolic heart failure. Causes of heart failure: ischemic heart disease, coronary heart disease, endothelial dysfunction, toxic drugs, heavy metals, medications, cytotoxic drugs for cancer, radiation, immune mediated, as in bacteria, lymphocytic infiltration, giant cell myocarditis, infiltration by malignant cells, infiltration other than the malignancy, amyloidosis, sarcoidosis, hemochromatosis, hormonal thyroid, hypothyroidism causes myocardial affection, and hyperthyroidism, of course, causes myocardial affection. Parathyroid, acromegaly, nutritional deficiency like thiamine beriberi, genetic abnormalities like hypertrophic cardiomyopathy, dilated cardiomyopathy, arrhythmogenic right ventricular dysplasia. Other causes of heart failure: valvular mitral valve disease, aortic valve disease, or congenital heart disease as ASD, VSD, pericardial constrictive pericarditis, pericardial effusion, endomyocardial fibroelastosis, volume overload as in renal failure or iatrogenic. Patient was given 4 liters fluids intravenous in short time. Arrhythmia, tachyarrhythmia and bradyarrhythmia can cause heart failure أكيد, surely. Symptoms, again, we will repeat. Symptoms as breathlessness, orthopnea, paroxysmal nocturnal dyspnea, reduced exercise tolerance, fatigue, tiredness. More specific, elevated jugular venous pressure, hepatojugular reflux, third heart sound, gallop, and even atrial gallop also. Less typical symptoms: nocturnal cough, wheezes, bloating, feeling, dyspepsia, loss of appetite, confusion, depression, palpitations, dizziness, syncope, bendopenia. When the patient tries to untie the shoes or bend down, he gets dyspnea. Less specific, weight gain or weight loss, tissue wasting, cardiac murmurs, peripheral edema, pulmonary crepitations, reduced cardiac air entry, tachycardia, irregular pulse, tachypnea, kynostalk respiration, hepatomegaly, ascites, cold extremities, oliguria. If the patient is having no symptoms and natriuretic peptide is normal and echocardiography is normal, then there is very remote possibility of heart failure. So these are the 3 items. If he is having clinical history of coronary artery disease, myocardial infarction, revascularization, hypertension, taking diuretics, is having orthopnea, basal crepitations, jugular venous congestion, all these suggest heart failure. Natriuretic peptide, if it is higher than 125 picogram per milli, and echocardiography if it shows hypokinesia, akinesia, dilatation, hypertrophy. So these are the diagnostic features of heart failure. Cardiac imaging is important to diagnose heart failure. Transthoracic echo to show the ejection fraction, the mass, the size. Other techniques we can assess by strain rate, or 3D echo. Cardiac magnetic resonance is very important to diagnose scarring, hypertrophy, mass. Non-invasive stress imaging by stress echo or stress ECG or stress SPECT may be considered. ازاي هنعمل اكسرسايز لعيان هارت فيلير مودريت ديجري اسمها سب ماكسيمال اكسرسايز، وبنتعمل حتى علشان بعد كده لما يروح يعمل ريهابيليتيشن نبقى عارفين حدوده قد ايه. Invasive coronary angio is needed if there is suspicion of coronary disease. Sometimes it is done to prove that there is no coronary disease. Invasive coronary angiography, cardiac CT is very important to diagnose not only the peripheral, the epicardial coronaries, can assess viability and reassess reassessment of myocardial structure and function. Also, diagnostic tests, very important. When I see a patient with suspected heart failure, definitely I will ask for blood count, sodium and potassium, kidney function, urea creatinine, liver function, glucose and A1C, lipid profile, thyroid function, ferritin, and natriuretic peptide. Natriuretic peptide is class 2A. Additional diagnostic tests aiming to identify other heart failure etiologies and comorbidities. You can resort to other tests for examination of heart failure other than these tests. 12 ECG, 12 lead ECG is very important. Of its first step, any patient with cardiac complaint, ECG is done. Exercise ECG, as I said, in heart failure, we can resort to submaximal test and not symptom limited, but less than symptom limited. And X-ray chest is very important. We forget it in many patients. We run for ECG and the echo and forget to do X-ray chest. Right heart catheterization only if the patient is going to have mechanical circulatory support, and thoracic ultrasound, echocardiography, ABC will be done for a patient with heart failure. Ultrasound measurement of inferior vena cava diameter may be considered to assess volumic status if there is constrictive pericarditis or endomyocardial fibrosis. These are examples of normal mitral flow. A wave, E is higher than A. In diastolic dysfunction, A is higher than E. Very severe diastolic dysfunction is called pseudo normalization. The E wave is higher than A, and this is very severe heart failure at the end. With very severe heart failure, there is tricuspid incompetence, and the pulmonary flow and is abnormal in patients with heart failure. This is an example of a patient with severe low ejection fraction. The septal motion is nearly absent. The ejection fraction of this echo is about 15%, and this is normal. So compare the normal mobility of the septum and posterior wall and the severe heart failure. Again, this is very severe heart failure. The septum is scarred and very low motion, hypokinetic, and there is dyssynchrony. The septum and the posterior wall are not synchronized. This case is improved if we give cardiac resynchronization therapy. Magnetic resonance is important to delineate scar, hypertrophy, masses. Heart failure with preserved ejection fraction. This is normal heart, normal size, normal muscle. This is low ejection fraction, dilated and hypokinetic. And this is diastolic dysfunction, hypertrophy, and the cavity is not dilated. Causes of diastolic dysfunction. This slide collects many causes that can lead to heart failure with preserved ejection fraction, ventricular dysfunction, atrial dysfunction, autonomic dysfunction, vascular dysfunction, elevated blood pressure, of course, lung disease. You imagine COPD can cause heart failure with preserved ejection fraction, iron deficiency, renal dysfunction, aging, obesity, of course, psychic depression, and valvular heart disease. This slide is important how to diagnose heart failure with preserved ejection fraction. That is diastolic dysfunction. Very large left atrium and very large myocardial mass. So left ventricular hypertrophy and the left atrial dilatation is sign of heart failure with preserved ejection fraction. Also abnormal E over A ratio. This slide is new for me. I saw it in one lecture. Scoring for heart failure with preserved ejection fraction. If the patient is obese, having atrial fibrillation, pulmonary hypertension, old age, feeling pressure by Doppler is more than 9 centimeter, this gives a score, and the higher the score, the definite heart failure with preserved ejection fraction. How to prevent heart failure? Treat hypertension, statins to prevent atherosclerosis, counseling, stopping smoking, alcohol intake, treating other risk factors as obesity and dysglycemia. Empagliflozin, the new drug for treatment of diabetes, EMPA and dapagliflozin can treat heart failure with preserved ejection fraction and heart failure with reduced ejection fraction. ACE inhibitors. ACE inhibitors class 1, but empagliflozin, sodium glucose transporter 2 inhibitor, class 2A. ACE inhibitors class 1, ACE inhibitors should be considered in patients with stable coronary artery disease if they do not have left ventricular systolic dysfunction in order to prevent or delay onset of heart failure. This is class 2A. Beta blocker class 1, ICD, implantable cardioverter defibrillator if the ejection fraction is below 30%. Pharmacologic treatment of heart failure, angiotensin converting enzyme inhibitors, beta blockers, and mineralocorticoids are important for heart failure treatment. This slide is very important. I found it in one of the lectures. Angiotensin receptor blockers reduce heart failure mortality by 12%. Angiotensin converting enzyme inhibitors, ACE inhibitors like tritase, reduce heart failure mortality in heart failure with reduced ejection fraction by 16%. Beta blockers reduce mortality by 34%, and mineralocorticoids by 30%. So this slide is important. The new drug, sacubitril valsartan angiotensin receptor neprilysin inhibitor, ARNI, can improve heart failure and improve mortality. And I write it frequently. Any patient with ejection fraction below 40, and recently they said even below 45 and below 50, it can be beneficial. Therapeutic algorithm for the patient with symptomatic heart failure. You will start by ACE inhibitors and beta blockers. Still symptomatic, you can add mineralocorticoid antagonists. Still symptomatic, you can add Entresto, ARNI, neprilysin inhibitor. This is class 1. You can try cardiac resynchronization therapy if the patient is having left bundle wide QRS below more than 150. The guidelines say more than 130, but definitely more than 150 is will get definite benefit. Or you give ivabradine. So ivabradine class 2 and CRT is class 1 or 2 according to the bundle block. If they are still resistant, give digoxin. But recently, new papers suggested that digoxin is more important and should be not at the end. And by the way, in fact, any patient with heart failure, I give digoxin. The guidelines say only digoxin if there is atrial fibrillation. But recent reports that even without atrial fibrillation, it is beneficial. Other pharmacologic treatment, diuretics, very important, and there are many diuretics, and many patients come with resistant heart failure. I increase the dose, but take care to increase the dose more than if the patient is fully dehydrated and oliguric and you give diuretics, it is harmful. So take care, don't be over aggressive. But in fact, many patients having low dose diuretics, if they are giving correct dose and full dose, they improve. Angiotensin receptor neprilysin inhibitor, I said I write it very frequently. Entresto, sacubitril valsartan, and the ivabradine, I write it also frequently for patients to control heart rate. The heart rate in patients with heart failure must be below 70. Either if not reduced by beta blockers, I put ivabradine, brocoralan with the beta blockers. Angiotensin receptor blockers, if the tritase converting enzyme inhibitors are not tolerated because of cough, you can give angiotensin receptor blockers. Hydralazine and isosorbide to cause peripheral vasodilation can be used, but take care, don't cause hypotension to the patient. Digoxin is class 2B. ICD, implantable cardioverter defibrillator, if the ejection fraction is below 30% to prevent sudden death. If the patient had previous recovered from sudden death, this is called secondary prevention. If there is no previous cardiac arrest, it is called primary prevention. Cardiac resynchronization therapy is very beneficial to improve the heart failure in patients with left bundle branch block, and the QRS duration is 150 millisecond or more. And the last webinar I attended, they inserted the third lead in the septal pacing instead of coronary sinus pacing. ICD is important, and CRT. These are the CRT is contraindicated in patients with QRS below 130, of course. Urgent electric cardioversion for patients with atrial fibrillation. Don't wait. NIHA class 4, you have to give digoxin and amiodarone. Patients with NIHA class 1 to 3 beta blockers. Patients with NIHA class 1 to 3 give digoxin class 2B. AV node catheter ablation and the implantation of pacemaker if the heart rate is not controllable at all. Again, in atrial fibrillation, cardioversion, pharmacologic or electric, beside optimal medical therapy. AF ablation and insertion of pacemaker. Amiodarone can be used for rate control rarely if very resistant heart rate. Dronidarone can be used, but it is not recommended for heart failure class 3 or 4. Again, dronidarone for class 1 and 2 only. 3 and 4 contraindicated. The prevention of thromboembolism in patients with heart failure and atrial fibrillation. This is another lecture. According to the SHAD-VASc, any patient with atrial fibrillation with a score 1 or more, you give anticoagulants. New oral anticoagulants are the recommended except in patients with severe mitral stenosis or moderate to severe. Other comorbidities must be corrected. COPD, stop smoking, lifestyle, hospitalization if the patient is not improving at home, renin-angiotensin blockers, evidence base for heart failure treatment is more limited, so comorbidities were mostly in exclusion criteria. You have to correct all other comorbidities as chest or thyroid or diabetes. Any drugs that can affect the heart, like non-steroidal anti-inflammatory, anti-cancer drugs. Any patient taking anti-cancer, the treating doctor refers the patient to me to do echo. If the ejection fraction is deteriorating or below 30, they cannot give. Again, the ACE or ARBs and the mineralocorticoid antagonists are class 1, thiazide diuretics are class 1, amlodipine, hydralazine, class 1. Intravenous iron is recommended more than oral. And if according to ferritin, if the ferritin is low, you give intravenous iron, intravenous or intramuscular, but they recommend this better than oral. And diabetes should be corrected. Treatment of valvular heart disease definitely is step in the treatment of heart failure, because if the heart failure is due to severe mitral incompetence, it will not improve unless you change the valve or you do the new method of mitral clip. This slide is very important and comes very frequently in the exams. Factors triggering acute heart failure. In the other address of this slide, decompensated heart failure, and other address, resistant heart failure. Very frequently, this question is in the exam. Causes of acute heart failure, acute coronary syndrome, new myocardial infarction, atrial fibrillation, ventricular tachycardia, severe uncontrolled blood pressure, hypertension, infection, pneumonia, infective endocarditis, sepsis, not compliant with the treatment. The patients stop the treatment either financial or due to depression, or take a lot of salt, bradyarrhythmia, toxic substances, alcohol, recreational drugs, methamphetamine, drugs as non-steroidal anti-inflammatory corticosteroids can cause acute heart failure or exacerbate heart failure or prevent it from recovering. Chronic obstructive pulmonary disease from smoking, pulmonary embolism, very important item to remember in the answer, surgery or perioperative complications, increased sympathetic drive, stress-related cardiomyopathy, metabolic and hormonal derangements as thyroid dysfunction. Of course, any patients with resistant heart failure or acute decompensation, I must check the thyroid function and diabetes. Cerebrovascular insult can deteriorate heart failure due to many mechanisms. Acute mechanical cause as myocardial rupture or stuck valve or trauma. Again, I brought the same slide to show how it is important in the exam to remember this. Acute decompensated resistant heart failure, non-adherence to medications, non-compliance or excessive salt intake, acute myocardial ischemia, again on top of previous infarction, hypertension, AF, tachycardia, bradyarrhythmia, negative inotropic drugs, alcohol, cocaine, endocrine as diabetes, thyroid, infection as anemia, renal dysfunction, other cardiovascular disorders as infective endocarditis and valve disease. In the treatment of acute heart failure, you need oxygen. By the way, oxygen is not given if the oxygen saturation is above 93. And here in this slide, according to the European Society, you give oxygen only if the oxygen saturation is below 90. Hypoxia, to be treated by oxygen. Hypercapnia is diagnosed if the PCO2 is more than 50 millimeter mercury. Oliguria, if there is oliguria. These are the items that should be corrected in heart failure. Again, initial management of a patient with acute heart failure, cardiogenic shock, you will treat it by pharmacologic or mechanical. Respiratory failure by oxygen. Identification of acute etiology. If there is acute infarction, you should resort to revascularization. Arrhythmia, you should resort to cardioversion. Pulmonary embolism, either by by lytic drugs. Immediate initiation of a specific treatment by ACE inhibitors, diuretics, beta blockers. Beta blockers only if the patient is not wet, if there is dry heart failure. Management of patients with acute heart failure, oxygen therapy only if the O2 is below 90. Non-invasive positive pressure ventilation. When to put the patient on CPAP or mechanical ventilation if there is deterioration and the oxygen saturation is not improving by mask. Intubation is recommended if respiratory failure leads to hypoxia, PO2 is below 60 millimeter mercury, hypercapnia, more than 50 millimeter mercury. Intravenous loop diuretics are important. You imagine the patient with pulmonary edema, how many ampoules of Lasix he may need, up to 12 ampoules. So don't think that 1 or 2 ampoules will be sufficient. In patients with new onset acute heart failure, receiving oral diuretics, initiate intravenous Lasix. Recommended to give diuretics either as intermittent bolus or as continuous infusion. Thiazide diuretics are not working in patients with renal insufficiency, so you can resort to loop diuretics. Vasodilators, if there is hypertension or the peripheral resistance is high, and if the blood pressure is above 90, below 90, you cannot give peripheral vasodilators. Inotropic drugs as dopamine, dobutamine can help to increase the cardiac output and support the circulation. Peripheral vasodilators, but take care not to cause severe hypotension to the patient. Nitroglycerin, isosorbate dinitrate, niseritide, but take care of hypotension. These are the doses of dopamine. Norepinephrine. Norepinephrine is important drug in patients with shock. Eligible patients for cardiac assisted devices. Dr. Magdi Yaoub became famous originally by implanting heart failure assisted devices. It's called MAT2. They are attached to the apex of the ventricle and they work to pump the heart. And he discovered that after 6 months, the myocardium improved and removed it. So it was a step towards improving the myocardium. It is implanted if the ejection fraction is below 25%. Thank you. I finished the heart failure. In fact, it was more than one lecture collected together. I hope the slides will be helpful. I will put it on my site, Samir Rafla Lectures, on Facebook, and on my site on internet, YouTube, Samir Rafla. The video will be put. So you can find the lecture in more than one site. Best wishes. Any question? Any question? دكتورة نهى.
أنا دكتور سمير.
أي سؤال؟
شكرا لحضرتك يا دكتور سمير.